Welcome, everybody, to February's Bra Banter. We are so excited to be with you today. And if this is your first time joining Bra Banter, my name is Jahan Corbin. This is my friend and co-facilitator, Lynn Haddad. We are both breast cancer survivors, and we work with an organization called Breast Cancer Recovery in Action. BRA is the acronym there, so you can insert your favorite supportive pun there. BRA is founded in Middle Tennessee, and we are honored to be able to go out into the community and to serve the breast cancer community primarily in four different components. We offer exercise groups with a personal trainer who is learned how to specially modify working with women who have had radiation to the chest wall and surgery on your upper body and lymph nodes removed and all those kinds of things that come with active treatment for breast cancer. We also offer education in the form of nutrition with a registered dietitian, as well as events like this, Bra Banter. And then thirdly, we have emotional wellness groups where we really work through in a group setting with two facilitators who are survivors. We work through the emotions and the kind of process what it's like to go through a breast cancer diagnosis, and then how do we move forward and live healthy and happy lives after a diagnosis like this. So that's what BRA is about. And if you are interested in getting more involved, I encourage you to go to bragroups.org. We would love to meet you and have you join what is a really fantastic community of breast cancer thrivers. So I'm going to turn it over to Lynn to introduce our guest speaker today. We're so excited to have her.
Yes, I'm so happy to have the privilege of introducing Dr. Melissa Kaufman, who is the Patricia and Rhodes Hart Professor of Urology at Vanderbilt University, and she is Chief of the Division of Reconstructive Urology and Pelvic Health. Thank you so much for taking time out of your very busy schedule to chat with Jahan and myself today. We appreciate it. Um,
Well, it's really an
every time.
honor to be able to contribute. So thank you.
Oh, thank you. When we do a broad banner, for those of you who have watched prior broad banners, we know that getting information on a topic like we're going to be discussing today can be very intimidating to many of our members. Interacting with highly esteemed physicians, particularly those from Vanderbilt and the other amazing medical providers in Nashville, can sometimes seem challenging and frightening. So we like to get a fun fact from our providers. And so at our first conversation, we did get a fun fact from Dr. Kaufman, which is truly amazing. In addition to the fact that Dr. Kaufman is a fly fisher person, I guess, right? Fan of fly fishing. And this is a tongue twister for me today. So we're going to see if I've had enough coffee. She flies herself out to go fly fishing, often, I believe, in Montana. Is that correct?
A lot in East Tennessee and
Oh,
Arkansas, which is my home state as well, but also Montana.
yeah.
Yeah.
It's like amazing. So, what made you start fly fishing? Like, where does this all come from?
Well, I like to tell people that I kind of picked a career and hobbies that embrace some of my pathologies, maybe. I'm a little bit meticulous about how I like things to be done. And I guess your interactions with me, you've probably figured that out already. And so it just really spoke to me, but it's very utilitarian. I think the most beautiful thing about both of those adventures is that it really reflects the things that I love. So in surgery, I love performing procedures and just being in that zone of focus where you're totally enveloped into the patient's care. And it turns out that my hobbies of flying airplanes and fly fishing put me in that same mental state. So that to me, they're very, very peaceful endeavors, although they're both quite active because I am so focused and in this kind of Zen meditative state when I'm doing them. So it just kind of reflects my personality and allows me to find space and peace outside of work.
Mm,
Huh, that's interesting.
I love that.
I think that's actually, I mean, I would say it's how many people feel about yoga, right?
Hmm.
It's like all-encompassing, focusing on the pose, but it's soothing to
Hmm.
be able to shut down their brain from worrying about things while they're focusing on that
Yep.
particular move. So I guess that's how I would interpret what you're saying.
It's really cool.
Neat.
Yeah,
All right. Well, so that's, I think, probably one of the most unique fun facts we've ever had on Broad Banner.
it
So
is.
thank you. You win an award on Groundhog Day today. So thank you. By the way, for anybody who's watching this later, we're recording on Groundhog Day,
That's right.
just to put that in context. Anyhow, so before we start peppering you with questions, we thought it made sense to start getting some background on the topic that we're going to be discussing with you today. So, Jahan, can you kick us off with some investigative questions, please?
Well, yeah, there's a lot to get into when we talk about sexual dysfunction. And so I'm just going to turn it over to our expert here as I share the screen because I know that you have a lot to speak to about this in women in general, but then in particular in our community of female cancer survivors. So take it away.
Yeah, I think this is really important to demystify and open up this conversation because part of my goal as a reconstructive urology and urogynecology and pelvic health is really to advocate for cancer survivors and remove barriers for treatment to improve quality of life. And so we have to bring these things to the forefront of the conversations. And as you'll see, as this conversation goes on, part of my national initiatives have really, I believe, helped shape how our government is allocating resources and also how they are describing and labeling some of the products that we're going to be talking about, particularly topical local hormonal interventions that allow you to know their safety profiles when we're discussing risks and benefits of utilization. So thank you for the opportunity. You know, female sexual function is it's a complex topic at baseline. And this is true for all women. It has a whole set of dynamic interactions that range from anatomic problems to hormonal problems and psychological influence, but it really affects up to 45% of women just in the general community. And then in female cancer survivors, I mean, it may be up to 90% of women who've undergone gynecologic cancers, but it's often extraordinarily prevalent. I would say it's at least 20% more for most cancer survivors, and specifically breast cancer because of some of the hormonal interventions and some of the issues that are undergone from surgical interventions. And
Mm.
there's lots and lots of different types of sexual issues that come on. And what I really want to express is I'm gonna give you a brief outline of what some of them are, but this is about ways that we can give you resources to regain sexual function. Right.
Mhm.
So I use the term dysfunction a lot because that's how it's labeled, but really it's about how we can reverse that and give sexual function back. And one of the most common things that we see both in the general population and the cancer survivor is a desire. It's a desire disorder. It's a lack of motivation, really, for sexual activity. Is you just have decreased thoughts and you're decreasingly responsive to any kind of erotic cues or stimulation. And it can be lifelong, but in most cases, this is really situational that is exacerbated or made worse by all the different types of treatments that you might undergo. And it's really dependent on hormones in many instances, you know, in that balance or imbalance. There are other types of things that are like arousal disorders that have to do with maintaining mental excitement or a genital response for activity. There's also orgasmic issues that can come in. And of course, there's pain. And sometimes this pain can be pre existing, but most of the time it comes on a contact from genital contact that really provokes a lot of anxiety. And many of these things can be treated very, very readily, but it's also just about basically moving forward to have that discussion. And that's where a lot of problems do come in.
So when I look at this 45% of the general population of women, is is that pretty consistent like throughout their whole mature adult life or sexual life that you're talking about? Or I think a lot of people think of that as in menopause. Or I'm just curious, like before we move forward, I'm looking at the context because could it be possible that these female cancer survivors were already having dysfunction and that it's compounding the issue? Or for some of them, is it new? Or I'm just trying to get a feel for where you're seeing most of the patients coming from.
That's an excellent question. I really do believe that it is based as an individual. Like this is going to be individualized, personalized types of therapy because
Right.
you never know. It all depends. Sometimes people who are doing very well and then lose some function, it's devastating,
Mhm.
right? And for some women who were already having some issues or were at a baseline that they were comfortable with, a degradation of that is not a big deal. So it's all about how it impacts any individual. And that's
Mm.
why we go into, and we'll talk a little bit more about this later. It's really shared decision making. And I know we throw around that term a lot. We throw around that term a lot in medicine as well. But what it really means is taking into account not just the information that's out there and the data about any particular intervention or treatment, but it's really about taking into account an individual's personal goals, what their value system is. There are plenty of women who don't have a value attached to sexual function, right? And that they don't see it as an important part of their experience. There are plenty of, it's less likely that I see men in my clinic that have that same, thought, but it does happen as well. And so we have to meet people where they're at in that situation. And so it is really, I can't give a number or percentage, but certainly you've hit on a topic that we have to approach this as on an individualized basis and to what's important to you. For many women though, like sexual health is part of your health. It's just part of who you are. And so to remove that and take it away, especially abruptly, as we see for many types of cancer treatments, is can be markedly devastating on a lot of different levels.
Yeah, I was gonna say something just to add on to Lynn's point. I know exactly what you mean. Like you can't, it's hard to pinpoint a certain percentage, but to treat everyone like the individual, that's so key because we, even without a cancer diagnosis, we as individual humans
Right.
are on such a different spectrum when it comes to age and stage of life and what is normal and et cetera. So I know like from our population with working with breast cancer patients, we are seeing, and this is a good thing because the imaging is getting better and better and better, but we are now seeing younger and younger women coming in 20s and 30s. A lot of them, I mean, they're very healthy. They might be marathon runners, whatever. So it's not like the old lady disease that it maybe once was, but that also affects kind of how they're coming in and like to your point, what the value system is for them, how important where they are in their life and their sexual health. So
Right.
that really is important. That makes a
And
lot
there
of
are
sense.
more preventative medications, right, for
Oh,
people who have genetic testing,
right.
and that can impact white women's bodies, which is
Exactly.
I mean, the ability to try to prevent, right, breast
This,
cancer is
right.
amazing, but it doesn't come without a cost,
That's right.
to the woman who's taking the medication.
That's right. Well, so you talked about, I'm going to move to the next slide here because you talked about the some of the factors of people dealing with these issues. If I
Yeah.
can get down to my, there we go.
There you
Okay.
go. The
The
biopsychosocial
biopsych, that's a
model.
mouthful,
That is mouthful.
biopsychosocial
Yeah.
model.
It's a big word, it's a big concept, but I think that when you look at it, there really are there's psychological influences, and we all know that these things can intimately interact with your experience with sexual health. There's medical influences like endocrine changes and all the direct, like vulvar and vaginal issues that come in, as well as issues that come after surgical interventions on our breasts, right? And then there's interpersonal issues. We want to be able to take some of that into account. This is the relationship. the life stressors, finances, all these things contribute to how your outlook about sexual health. And then some of it's upbringing too. A lot of times I will see women, and when we begin some of these conversations, they're very uncomfortable because even with a physician, even with a female physician, even with a female physician who's trained to have these conversations, it's still a lot to break that barrier. And because of their upbringing or because of some cultural norm that they have, that they don't feel comfortable discussing sex, discussing, they're like, oh, well, and the barriers are existent, not just for women who have undergone cancer treatment, but I think it becomes much more complicated for women who have, because a lot of the time the physicians themselves that you're working with also are not comfortable dealing with these issues. They don't have the training, right? You're seeing an oncologist, you're seeing a surgical oncologist, you're seeing a medical oncologist. They don't really have sometimes the resources for the referrals. They may believe that, waiting for you to bring it up, so they're not going to bring it up, ideally, or there's not time. Really,
Mm.
we're managing other things in the interaction. There's not time, but most of it is not having the education and training to be able to intervene. And so my colleagues and friends who have been cancer survivors have told me that, the number one aspect of any type of issue that's not being addressed is your proactive nature, right? And that's what everyone on this call is already doing, right? Everyone's already being proactive to look forward to what can I do for myself to be able to overcome some of these issues. So it's about you opening that conversation more than anything, because I would not rely on the oncologist to be bringing these things up. You just open the conversation with something as simple as like, I've noticed this, or I'd like to know how this treatment may impact my sexual function. Or since I started treatment, these are some of the things that I've been experiencing. So that can be powerful for you to gain access to someone who will be able to provide you treatment.
There are so many obstacles, but I love, it's wonderful to know that there are resources like you out there. So I'm just curious, in your practice, do people tell you that do they get a referral from their oncologist if they've had that conversation with him or her, or do they, and I'm also curious, it's kind of a two-part question. Do you hear people, particularly cancer survivors, who say, well, I've been suffering for 5 years, but I'm finally here to see you? I mean, as opposed to kind of they're coming out of treatment. Does that make sense?
It does, and it's you've really put a laser focus on the profound nature of some of these issues, and that we often, for what they now consider a quality of life issue, that will be shuttled away from, your deep appreciation to the oncologist and to the team that's brought you through, and that you're now, labeled as survivor, which is absolutely marvelous. But all these quality of life issues then take kind of second stage, and it turns out you used a metric of 5 years, and when we look back on our population of cancer survivors who come to our clinic, men and women, on average, their primary treatments were 5 years ago,
Hmm.
right? Before they come in and gain access to, and we all know, like, you want to live every day, right? No one knows that better than a cancer survivor
Yeah.
about the importance of having an experience and a quality interaction every single day. No one else can appreciate that. Most other people can't appreciate that as well as you do. And so the fact that now there's been this 5 year span where all this missed opportunity is tragic.
Hmm.
So I go out and I do these types of conversations in hopes of getting people to recognize and call and say, I want appointments. I need to speak to a urogynecologist. I need to speak to someone about these issues. But and we collaborate as well with our cancer survivorship clinic, at least at Vanderbilt. And so reach out to your cancer survivorship resources and say, hey, I need to see somebody for those issues down there because they're important.
Right.
And most places will have an opportunity. But again, this is, it's your initiative to find that resource sometimes, which is unfortunate that it's not baked into the system, but it's not.
Mhm.
Do you think that, I mean, 5 years, right? 5 year survival rate, that's the name of the game when you get a cancer
Sure it
diagnosis.
is.
Do you think that that's maybe why that number is out there? That everybody's consumed by making it those 5 years, and then you're like, okay, I've gotten here. Now I can turn my attention to fine tuning and actually trying to make my life a little bit better because everybody's not telling me to be grateful I'm alive. I
Mhm.
can actually, focus on the
Just
details.
start living now,
Yeah.
right?
Right.
I see many women though that develop these problems during active treatment.
Yeah.
Mhm.
And so it is completely reasonable. Again, we go through a shared decision-making model where we will have collaborative conversations with medical oncologists, with surgical oncologists, with primary care physicians about initiating treatment even in the midst of active therapy. So
Mhm.
yes, we want to utilize aromatase inhibitors. We want to utilize selective estrogen receptor modulators. We want to utilize all these things to withdraw estrogen from the systemic system. But that doesn't mean that if you are absolutely miserable in symptoms that can come from basically a forced genitourinary syndrome of menopause, where you have vaginal symptoms, where you have urinary symptoms, that we can't treat those because we can. Right?
Do some of
So
the
it's
symptoms,
about doing this at any phase.
right? I'm sorry, I didn't mean to interrupt you.
Oh
But
no.
do some symptoms improve like after treatment ends? Like is that a thing? Like I can say from personal experience, from my first chemo infusion, I immediately went into menopause. And so I think I was hoping that maybe things would return to a more normal state after I concluded, infusions and everything, and my body would get back to being more normal again. Everybody's hoping, right? And they don't know what the future will bring, even if that current situation is really bad. And particularly because there are more and more younger women
Mhm.
being
Mhm.
diagnosed who are then being put on AIs and various
Well, that was
types
what I was going to
of
say. The very.
hormone suppressants, right? And I mean, after
Mhm.
they do the time and they do their 5 years or whatever it is that they're being told to do, perhaps they're hoping, well, then maybe everything will get back to normal and I don't really have to go down this road.
Mhm.
Do you find that? I mean, does sometimes do the symptoms go away? And not to give false hope, but I'm just curious.
Well, sometimes they will abate, and but most of the time there's going to be some sequelae, and a lot of the time they are so severe that they are almost intractable, and the suffering, like it's enough to go through chemotherapy or
Right.
radiation and surgery. It's enough to have your body withstand that. And then on top of it, to have all these symptoms of basically the genitourinary syndrome of menopause. So terrible dryness, terrible burning,
Mhm.
discomfort,
Mhm.
pain with putting on underwear, overactive bladder symptoms of having to pee all the time or having leakage, having pain with intercourse, having recurrent urinary tract infections. I mean, that just to me adds to the suffering. And even
Right.
if we're able to taper or titrate off the therapies later on, after
Yeah.
you now have stopped the therapy and have replenished some of this, like getting that type of intervention can salvage so many things in the interim, including, like we said, this biopsychosocial model, including your outlook
Mhm.
Hmm.
of your future, including your partner's outlook
Absolutely.
on your future and intimacy together, and how that plays into the entire spectrum. It's part of healing.
Right.
you know your genital health, your sexual health, and your bladder health. It's all part of your healing. In addition, and I just feel that many women will do exactly what you say, exactly what you said, which
Mhm.
is I want to wait until there's a mark. Maybe this is going to get better on its own. Right.
Right.
And we know for a fact that even if it does, there are probably going to be some long-term issues that will
Mhm.
still need treatment.
When the problem with that is also just the time frame involved. I mean, it's one thing, yes,
Right.
chemo often kicks us into medical menopause. It did for me as well, but chemo can be, and it's rough. I wouldn't want to do it again, but it's usually a year or less, maybe 6 months, something like that.
Mhm.
But the aromatase inhibitors and some of those long-term medications, I mean, I'm going to take those for 10 years. I'm 7.5 years into a 10-year regimen, and you better believe I'm counting the days because I'm going to have a party and go somewhere tropical and I have to get to stop taking those stupid medicines. So even if it was going to come back
Yeah.
after we stop taking the medication, 10 years is a long time to
You're
be
going to be in a
dealing.
whole different stage of life,
Exactly,
frankly. I mean,
exactly. I mean,
it's
and
no
10
going
years
back.
older than I was, right? So
Yeah.
that's part of it too. So just the length of
Right.
time to suffer with some of those symptoms is really, it's like, why not take
It's like a
advantage?
jail sentence.
It is. It
Well, and I say, would you do this if it was, bone pain or your joint pain? Like people will not want to address this, but they would be willing to address joint pain or other side effects. Is, so I'd be kind to yourself.
Sometimes
I
it's
would say to
easier to
anybody
talk about those
listening,
things,
treat
right?
yourself well.
It's easier to talk about joint pain. It's easier
That's
to
right.
talk
Yeah, it
about
is.
those things
Easier to
than
ask
it
your
is
loved
to
ones
bring
about those
up like,
things.
Sure, everybody
but
knows
it
that.
is, and it's not just the genitals, right? Sexual function and cancer survivors, like there can be lots of things that go from just, hair loss and
Hmm.
the brain fog. Like
Right.
all these things contribute to loss of sexual health and sexual function.
Well, on that note, let's get into the
Right.
sexual function of cancer survivors
Well,
and then maybe
let
some
me
of the
just say one
treatments.
more thing before we move on,
Yeah,
but you
sure.
can take that
Go
away.
ahead.
No, in our bra groups, emotional wellness groups, which Jahan and I actually co-facilitate, and we have new groups starting right now. But one of the things we talk about is coming to terms with loss as a cancer survivor, and that some things never go back to being the way they were. And it's something that we encourage people to come to terms with and just to look forward and kind of re-envision the future. And it's just part of it. And this is an area where truly many, many survivors have to come to terms with a loss of some sort. It's a change that we didn't ask for. And to us, that's a loss. And to me, there is no area where that resonates more clearly than this.
Hmm.
It's, it can be, we talk about weight loss, we can talk about people letting us down, and, having any sort of change in sexual function or the way those organs operate is a loss. And it's something to be that, particularly in our groups, find a group, find a friend, find your community,
Hmm.
and find something you can confide in and
Hmm.
talk about, and then get medical
Hmm.
guidance
Yeah.
because it's not something that anybody, I think, should have to wrestle with alone.
Yeah. Just to acknowledge
Life
that it
is
truly is
better
a
when you
loss.
have
Yeah,
somebody to share it with and when you can reach out and ask for help, in my opinion.
I agree.
So that's my little soapbox.
Well
Yeah,
said.
I gave a lecture recently to the Vanderbilt Ingram Cancer Center. They had a young cancer survivor symposium. So, not only these things about sexual health that were so prevalent, but some things that some of us might not think as much about, such as fertility, like loss of the future for
Mhm.
fertility. I mean,
Hmm.
you can grieve a great deal about the envisioning what your future was going to look like, and then having not just the cancer and surviving a cancer, but looking at those types of things that some of us may not be, in that same space. So I think for the young cancer survivors in particular, this is extraordinarily difficult to manage. And one of my colleagues, who was one of my residents, specifically when I had reached out to her as a breast cancer survivor, I had reached out to her and said, "What are some tips that I need to give these young cancer survivors. And she mentioned PsychOnc right away. She said it was so helpful for her to have a resource to speak to. Because she was going through all the different states of grieving about her loss, and people are very loss averse, and we all know how that impacts every other aspect of your interaction. So I just appreciate you sharing that, and want to echo that I've certainly heard it from people who are physicians and cancer survivors.
Mhm.
But as we see in this slide, I mean, it's one that I actually got from Sarah, who gave me that um, information as you know as well. Is that these are all the things that may be impacted. So it's from head to toe, basically. There's no organ system and no aspect of your being that may not be impacted by these types of interventions. And because they're important, right? We have to have them, and you have to advocate for yourself. But there's a lot of misconceptions about what's going on out there and what we can do, right? And I just wanted to give a little brief synopsis of what some of those things have been real barriers to treatment, particularly for breast cancer survivors. And the biggest one was something that happened way back in 2002.
Okay.
So this was 24 years ago. And that was actually the year that I first came here to Vanderbilt. But there was this giant study called the Women's Health Initiative. And it linked use of estrogen and progesterone to cardiovascular risk. It linked it to breast cancer. It linked it to dementia. It linked it to blood clots. And so the FDA, right, just put this big black box warning on everything, on every estrogen product. And the fact is that for genitourinary syndrome of menopause, for many of these local complaints that women have about that impact sexual health, like the dryness, the burning, the urologic symptoms, the UTIs, uh, our number one treatment really is a topical low dose vaginal estrogen. And so when we talk about using this, there's this black box warning. And it turns out that when they go back and they looked at the women's health study just 2 years later, that there really isn't a breast cancer risk for use of topical low dose vaginal estrogen. But it took until April of 2025 for that warning to be removed. And so we like to think that part of initiating these guidelines, we put out guidelines on treatment for genitourinary syndrome of menopause, where we actually looked at what happens in breast cancer survivors, what happens in women with breast cancer, what happens in women, with treatment on aromatase inhibitors and selective estrogen receptor modulators. And it turns out that the data is very strong with regards to a lack of evidence linking low dose vaginal estrogen to the development of breast cancer, and that it can be safe for women who have had breast cancer. So there was a lot of reassurance. And we think that this helped change the FDA's perception. And so they actually removed this black box warning. Now, it doesn't mean that all the providers know this, and it's certainly like this is part of our outreach, is to be able to spread the word to people that this black box warning is gone and the data is just not there that links these things together.
So, okay, I have two questions.
Yes.
Why is it not a concern? Because it's not absorbed into the body? And why on earth did it take so long? Okay.
And we're also, and to clarify, we're talking about topical
Right. This
estrogen,
is
correct?
not right.
Yes, we're talking about use of low dose topical vaginal estrogen.
Right.
Okay.
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 So when you apply topical estrogen,
Mhm.
there is a small spike in systemic levels to very like way postmenopausal levels if you look at the blood, and it lasts less than 8 hours. So it's a very small transient increase in systemic levels. And in fact, when you look overall for a lot of women, that when you look at the concentrations in the blood after 2 weeks, they're almost the same as postmenopausal women and almost the same as placebo. So it doesn't manifestly really increase systemic levels of estrogen to use low dose vaginal estrogen, to a degree that it is very rare for a medical oncologist when a woman has severe symptoms to not allow use of vaginal estrogens. There have been studies from the Women's Health Initiative as well as the Nurses Health Study that have looked at not just at breast cancer risk, that have looked at women who have taken tamoxifen as well. Like there's reassurance that use of vaginal estrogen is not associated with increased risks of breast cancer. There's a single study with regards to aromatase inhibitors that does note that there was a small increase. And so this is something that we have to take into account as a shared decision-making model. This was a small Danish study, or a Danish study. It wasn't small, it was 8,000 women who had estrogen receptor positive. And there was an increase in those women who were using vaginal estrogen of recurrence, but not of mortality. No one wants that, but it depends on a shared decision making, how bad the symptoms are, right? So we want to be able to give all the information and help you judge, is this something that would be reasonable for me in a shared decision making model?
Is there any sort of research being done for like a synthetic or a non-estrogen supplement that would have the same impact? Because that would be maybe the best of all worlds, right?
It sure would. We have a
I would
lot
like to
of different
invest in
types of moisturizers,
it.
a lot
Yeah.
of moisturizers and lubricants. Most of these can be used either in combination with other therapies or used alone for women who have these symptoms. And so moisturizers, these are meant to be used. There's a number of good ones that are out on the market, or you can use things like cold pressed coconut oil, which is a solid, and you can get at any grocery store and use as a moisturizer there. But they will help abate some symptoms. They're not as powerful as topical vaginal estrogens, but they can be utilized to abate symptoms. And then we also have lubricants, and lubricants are like one off to be utilized at the time of sexual activity. So not on a daily basis. So both of those can improve vaginal dryness. They can improve pain in women who have GSM. There's also been a huge uptick in women who are interested in other types of interventions, who want to completely avoid hormone therapies, things like vaginal lasers. Right? We've all seen advertisements for this. It's not really vaginal rejuvenation, but we've all seen advertisements for vaginal lasers. And it turns out that although the evidence is really not compelling for their use for these symptoms, it's likely very safe. And it can also, if you believe that it may be worth it, if you really, really want to avoid all the estrogens, to trial it. And so we've given latitude for that when we wrote guidelines about this, to have patients who would, in a shared decision-making model, despite the fact there's not strong evidence, it doesn't mean that it won't work for you. So it may be worth having a discussion with a provider who does those types of interventions to see if it would make sense.
I wonder about treatments, if you don't mind speaking to this, for decreased libido. What can be done when our drive just takes a nosedive?
Yeah. So again, utilizing things that may really help the local environment can often help, but there are pharmaceuticals that are specifically designed for hypoactive sexual desire disorder. There's one called flubanserin, which it increases certain hormones in the brain, things like dopamine, and decrease it, that kind of help drive part of our libido. So it's been known to increase desire and decrease distress about sexual activity. The one thing that's been a limitation to more widespread use, well, there's really two things. As with most things, most pharmaceuticals, it can be cost, right?
Mhm.
But you can't utilize it in combination with alcohol.
Um,
So that's been a downside for a lot of people that they can't concomitantly take those medications. There's also one that's a melanocortin receptor agonist, and it's an on-demand kind of injectable agent, and it can improve also desire and decrease distress. And so these are well documented FDA-approved medications for sexual desire. But the issues often come in with the affordability and the side effect profile from them that doesn't make them readily and widespread adoption for women.
Are estrogen supplements by prescription only?
They are,
And
yes.
are those
But we
usually
have
covered
lots
by
of different types.
insurance? Are those usually covered by insurance?
They are.
Yeah.
We have lots of different types too. So some women will find that utilizing estrogen cream that's been out, since the early, there's been some that have been out since the 70s, but some that have been out that we utilize frequently since the 1990s. That utilizing that is messy, right? They don't
Yeah.
like that. If I give you a prescription and it sits in a drawer because it's
Mhm.
messy or it's gooey or it's expensive and it doesn't get refilled, it's not going to do us any good. So
Right.
there are lots of different formulations. There is a ring that can be inserted, it's a little like a diaphragm. There are tablets that can be inserted. There are other types of vaginal inserts that go in, some of which also deliver a little bit of testosterone, which is important for some of the tissues in the vestibule and the vulva. And so these kind of things, there's lots of options. You find the one that's going to work with you. And then of course there can be barriers to some of these with insurance. So we'll work and sometimes we'll compound the estrogen products as well.
So I have this crazy question. I was on a plane a couple weeks ago, and I don't know, the Wi-Fi wasn't working, so I was watching the movie, and I don't know, it was a sitcom, and it was about this man who was a small town doctor, and there was an outbreak of, for some reason, something's printing in our room. Um, these men were developing breast. And it was because the woman was taking vaginal estrogen. And ultimately, this guy determined that it was the vaginal estrogen making the men get breasts. Is that really a thing? Like, can the men
That
absorb
is an awesome, awesome
sexual
question.
content? And do you have to tell the
Right.
partner, like, because there are some women who don't want to talk to their partners about this
That's
old
true.
fashioned, right?
Hmm.
It's part of this whole
Absolutely.
conversation. So is this something one needs to disclose?
Hmm.
Could the male possibly have any negative um, side effects?
Hmm.
And
Right.
including growing breasts.
Wow.
It was just a
That
stupid
is an
show.
No.
awesome question.
But it was, I was
So,
going to
there
Phoenix,
are warning
line
labels.
flight, no Wi-Fi. Line flight, yeah.
There are warning labels on testosterone gels to avoid contact with other people, while you're using the testosterone gels. So, because it can have an effect if there's enough absorption through the skin on women. Just like what we see with those serum levels in women, the same type of almost non-existent risks occur for male partners. So if you're having penetrative intercourse after you've applied vaginal estrogen,
Mhm.
your male partner is not going to have any side effects from it.
Right.
They're not going to grow breasts. I mean, maybe we could hope they would act a little bit more like women, but that's not going to happen either,
Yeah.
right? So really there's no concern with regards to exposure of your male counterpart during penetrative intercourse after using vaginal estrogen products.
Well, thank you to TV for perpetuating these stupid
The
ideas.
I
the
know
the
I mean
myth,
Not
that
right? It's
helpful.
not actual
that's
information.
amazing.
That is crazy.
Yeah.
Okay, well, let's talk about switching gears just a little bit for preventative. What can someone do if you were seeing someone that had recently been diagnosed with cancer and you wanted to encourage them to ask certain questions even to their oncologist, or is there anything that we can do to help prevent some of this dysfunction from occurring?
So the number one thing is just be armed with the knowledge that these things can occur and that early treatment can help you eliminate a lot of the symptoms that you'll be enduring. I mean, I always tell patients, and I think that people don't recognize this as much. One of the main things that you can often do for your lower urinary tract, your vaginal health, and your general health overall, especially when you're undergoing cancer treatment, is simple. It's water. Can you see it?
I
It's
knew you were going to say
water,
drink a lot of
right?
water.
Drinking lots of water. It is amazing. It will flush out issues. It will help with all your urinary issues. It will help hydrate the tissues. But I think early use of things like vaginal moisturizers, which again are readily available, will kind of preclude like development, because once those tissues really start to devolve and have problems, it's more difficult to rescue from that, right? So utilizing vaginal moisturizers early on, but having the conversation just so you've opened it up to be able to, you know, or readily reach out. And I can't say enough about the other types of things that you're supporting with BRA, including exercise, including having a peer group to discuss these issues with, including all this information for patients. It's that's the most powerful preventive for things happening, is when you recognize it and then you can seek treatment early.
Awesome.
And
Wonderful.
exercise makes you drink a lot of water.
Right. It's a good cycle to get
It
into,
is.
right? This is a
Yeah.
good
It's a
one.
good cycle,
Yeah.
right?
Right.
Well, that was very
Okay,
informative. I feel like we
wonderful.
could talk about this all
I know.
evening because there are so many things to get into, and you clearly just have so much knowledge and expertise about this. But I feel like we've done a good job of hopefully summarizing some of the treatment that's out there. I know you're at Vanderbilt, and some of our listeners are likely in Middle Tennessee also. Are you in your clinic taking new patients right now, or what's the situation if
Oh,
somebody?
absolutely.
Okay.
Absolutely.
Okay.
We're
Yeah.
we're we're delighted to help with all of, I mean, there's lots of needs that come in as outside of some of these types of issues as well in that same area,
Right.
right?
Right.
Sure. I can only
So
imagine.
yes, we're delighted to assist. And I want to, I'm going to share with you my that you can put up on here my email,
Right.
Okay,
because let
great.
me just tell you, getting through sometimes to getting scheduled in clinics is a challenge, right?
Mhm.
You've been through enough. You don't need a challenge just trying to claw to get to a doctor who wants to be able to help you. So I'm going to share my email, and just email me and I can help expedite and accelerate some of that. We have a clinical coordinator who is fantastic and will be able to vet whether this is in our insurance. I can always give suggestions for people that might be in the insurance system or in the health system that you're utilizing, because I have lots and lots of colleagues throughout the community in Middle Tennessee that are trying to do the same thing, to be able to give you some peace of mind, some better sexual health, some better urinary health, and really help you thrive as a survivor.
Oh,
I
that's
love
so
that. I
kind
wish
of
it's so
you.
kind of you. I was gonna say I wish more providers had that same perspective because it really is so helpful. And sometimes the access piece of it makes you want to beat your head against the wall. And it's not the doctors,
Correct.
that it's not, it's just the red tape that gets caught up. One more question. I'm just curious, what was your journey into this field? Like were you in medical school or residency, or when did you really develop an interest in this particular field?
So, I am a recovering microbiologist.
Oh,
And
Recovering.
more
recovering.
fun
I love
facts about me.
that.
I got a doctorate after my undergraduate in microbial genetics.
Wow.
So I was looking at host microbe interactions. And I chose this marine model system, and I actually worked out at Stanford, and I was down in a lab by the Monterey Bay Aquarium. And so
Nice.
I remember I'm doing my pipetting in the lab, looking out at all the dolphins and whales cavorting in the bay, little sea otters eating abalone. And at some point decided that I want to, I was actually studying something that was looking at how bacteria interact with their environment. And we started in on discussions about how this may work with regards to things like infections in women.
Mm.
There was a lot of corollary here. So it was the first spark of interest. And then I ended up going back to medical school. And then when I got into urology, which I didn't anticipate loving, but one of the beauties of this field and the thing that gravitated to me is that it is such an intimate interaction that you have with patients, because that vulnerability of talking about these types of topics, you have to have an appreciation for, like, what it takes for a woman or man to come forth and discuss these very, very personal topics. And so I felt that it was just such an incredible opportunity that very few people would ever have the chance to get. And for some reason, I naturally gravitated to caring for women and men who were cancer survivors, because there was so much that was overcome and overtaken. And I have some very close family members who were in the same situation. So it kind of drove me to be able to try to find some solutions.
We're so
That's
grateful you did.
wonderful.
We're the beneficiaries of that decision for you. So thank you so much.
Yeah.
Well, we appreciate your time
This has
today.
been
This has been
wonderful.
amazing. And if you want to you want to say your email, and I'll also write it in the chat as you're
Yeah.
spelling it.
I think we
Yeah,
can put a link on the Bra Group's website underneath this video
That's
as
true. We can do
well.
that.
sure. But it's Melissa, Melissa dot Kaufman, Kaufman, at VUMC. So that's Victor Uniform Mike Charlie .org. So
Okay.
Vanderbilt University Medical Center, VUMC.org. That's perfect. That's it.
Awesome. I'm going to
Yeah.
just say that in the chat for people who are listening or watching the recording, and then also you can hear it as well.
Yeah.
So, okay. Thank you so,
So
so
much.
much. This has been amazing. We appreciate your time.
Yeah. Thank you so much.
Thank you.
All right.